All right, guys, here is my attempt at recording a lecture. This is for the cardiovascular system. It says part 1 because I don't want to create this huge, long recorded file and have it difficult for anybody to upload. So I've broken it down into a few different parts. Part 1, which we're going to do right now, this is going to include cardiac anatomy, cardiac function, and systemic circulation. Part 2 is going to have cardiac disease, cardiac dysfunction, and part 3 is going to have vascular disease and shock. So, like I said, in this recording, we're just going to focus here on part 1. Our cardiovascular system, this is meant to deliver oxygen, nutrients, hormones, and immune system components all throughout our body. And then we have our lymphatic system, and that removes waste products of metabolism and infectious organisms. We're going to talk about cardiac anatomy on this slide, and I know there's a lot in this picture. It is really important for you to know everything in this picture, though. We've got our pump, right? This is the main component of the whole circulatory system. It's got 2 pumps, technically. You got your right and your left. And the right pump, this is for the pulmonary circulation. So this is the circulation that's going through our lungs. And if you look at the picture on the left, you can see, let me get my arrow here. You've got your heart pumping out into your left lung and your right lung. So looking over here, you've got coming from your superior vena cava. So this is from your body. After it's gone and circulated through, it's going to come back because it wants to get reoxygenated. It's going to come through your superior vena cava, dump out into your right atrium. It's going to go through the tricuspid valve into your right ventricle, up through your pulmonary valve, and into this way and this way into your lungs. Once it circulates through your lungs, exchanges the oxygen and the CO2, it's going to come nice and oxygenated all the way back into the right side. So it's going to come in through these pulmonary veins from your right and left lungs, dump into the left atrium, go through the mitral valve, into the left ventricle, out through the aortic valve, into the aorta. And it's really important for you to understand this and the flow and how it goes and where these valves are to really help you understand disease processes that go on with the heart. And so that it makes sense. And I know it's a lot, but it is important. So the left side is for our systemic circulation. So we just circulated blood through our lungs, and now we're going to circulate it through our body now that it's oxygenated. So back over, looking on the left-hand side here, once it comes out of the heart into the aorta, it works its way down from large arteries to smaller ones to arterioles and into our little capillaries. You have your exchange of gases there, your O2 and CO2s from metabolism, cellular metabolism, into our venules, veins, larger veins, up through the vena cava, and dumping it right back here into the right side of the heart. Looking at the layers of the heart tissue, we've got 3 of them. We've got the pericardium, we've got the myocardium, and we have the endocardium. And then the whole heart sits within inside the pericardial sac, and the pericardial sac is full of fluid. It prevents displacement, so it helps to stabilize the heart that's just hanging out inside our chest. It creates a physical barrier against infection and inflammation that can happen from pneumonias and other things going on in the lungs and the pleural space. It also contains pain and mechanoreceptors, so it can sense things that will help be protective of the heart, increases the blood pressure, heart rate in times of stress and trauma. The pericardial sac is full of approximately 200 milliliters of fluid, and this helps provide lubrication with each of the heartbeats. We're going to talk about processes that can actually affect the volume of the pericardial sac in a few slides ahead. Now talking about the vasculature of the heart. This is, another really hairy picture, I understand. This anatomy is not anywhere near as important as what we just went through, but it does give you kind of an idea of how the myocardium is infused with oxygen through these arteries, and why it's so important when things go wrong and we have clogged arteries, right, causing things like heart attacks. Our major arteries are the right coronary artery, the left coronary artery, circumflex, and LAD. They didn't have the LCA on here, so I drew it up here. But these are our main arteries that are going to be feeding our right and left pumps of our heart. Cardiac work, this is really just a description of the amount of oxygen that needs to be consumed in order for the heart to do what it needs to do. It's dependent on the amount of stress on the heart wall during systole, which is each one of the beats, the duration of the wall tension, so how long that pressure is there, and the contractile state of the myocardium, so how flexible or stiff the myocardium is. And that's going to determine how much cardiac work there is, how high the oxygen demand is. And so we'll have collateral circulation develop as we age and things don't work as well as they do. Our arteries start to get clogged up. We're not able to deliver the oxygen that's demanded of our heart in certain situations. So when we have things build up like plaques here, atherosclerotic plaques, over time you can see that the flow just doesn't really go through so well. So our arteries will start to work around and build what this is called as collateral circulation to help make sure that we're still able to get oxygen to these tissues as our roadways start to become a little too bumpy or blocked off. And looking at the muscle and how the muscle functions, this is kind of a little bit of a hairy slide, but we've got pictures here comparing skeletal muscle, cardiac muscle, and smooth muscle. And the cardiac muscle is significantly different from any of the other muscles in your body. One is that it has what are called intercalated discs, and you can see in the picture these little striations, these little lines here. These intercalated discs help to move action potentials really quickly through the cells. And this is what's able to make us adjust very quickly with our heartbeat. The cells also are able to maintain high levels of energy synthesis. There's like a quarter to a third of the volume of the cell is just full of mitochondria. So it's just pumping out a ton of energy. Skeletal muscle has, 10% of what cardiac muscles have. It also is able to gain more ions, particularly sodium and potassium, than any of the other muscle cells are. And it also has these units called sarcomeres. And they contain a bunch of multiple proteins that help with relaxing the muscle. And one of the things that we measure when there's issues with cardiac function is troponin. And you guys may know that from the clinical setting, but troponin is a very important protein, and that's located within the sarcomere. Calcium is super important in the function of the myocardial cell. It's what binds to troponin and facilitates the whole contraction process. And I know that we've talked plenty about action potentials and sodium and potassium pumps and the role that these play in action potentials. And I just wanted to throw this image up on here to give you an idea within the muscle cell what's going on, where you have an influx of sodium coming in here, fills up really fast, sodium channels close, you've got the slow intake of calcium here. And this is the part that's really important when we talk about calcium being really low in somebody's body. We don't have the calcium here to help in this refractory period, and that's what makes the cardiac tissue really irritable. And this period here, this refractory period, is depicting the QT portion of the EKG, and we'll talk about EKGs in slides coming ahead, but it's a very sensitive time in the whole cardiac cycle where the cells can get depolarized and repolarized in a fashion that ends up throwing it into a dysrhythmia and can actually cause cardiac arrest. So This is just a really important part of the cycle that I just wanted to show you, and how important the calcium is in the process of the cardiac muscle function. So the conduction system is shown here in green. You've got, this is also an important system for you to understand where things are located. You've got two pacemakers in the heart. They're heavily innervated by sympathetic and parasympathetic nerve fibers, but they don't even need our nervous system to go. It's complete automaticity in these cells. The SA node, or sinoatrial node, this is our primary pacemaker. The normal rate for our primary pacemaker, it's just set to go between 60 and 100 beats per minute in a resting state. And when everything's working well, this is exactly how it should be. However, we do have another pacemaker, and it's the atrioventricular node, or the AV node. And generally, in a normal state, you have your SA node sending out the signals, depolarizes your atria, and then it hits the AV node. And the AV node really just takes that signal and delivers it on down to the ventricles. However, there are situations where something goes wrong and the SA node just really isn't doing its job. And the AV node is like a gatekeeper. So it's really only going to send that signal down if it makes sense. So in a normal heart functioning fine, your heartbeat is going to be whatever the SA node sent out. So if it's 60, it's going to be 60. However, in situations like we know with AFib and other situations where maybe the SA node, there's a block for some reason, it's just not functioning. So the AV node will take over. If there is a complete block and the AV node is not getting any message whatsoever from the SA node, it will be it'll take over and it will become the primary pacemaker. But when it does, it only has the capability of beating the heart at 40 to 60 beats per minute. I have no idea why, but that is the situation. So I just wanted to put that on there, that that really only happens when the SA node is shot for some reason. Then moving on past the AV node, you have the bundle of His. It's going to go down into the bundle branches, and then finally into the Purkinje fibers, which are the little hairy things down at the ends of the ventricles. I need a sip of water, hang on. There is no editing of the video, so yes, you have to listen to me drink water and stuff. Anyhow, here we have your EKG, right? It's super pretty. And I just wanted to give you an idea, now that you've seen that electrical system, when you guys look at an EKG, what does that mean? How is it related to an actual heartbeat? So there's just two pictures here. They relate to each other. And it's just one might make more sense. So you can picture this instead of just reading SA node. You can look over here and be like, okay, SA node, whatever makes it easier for you to learn. But at the beginning you have the SA node, and it fires, it sends out its signal, and it depolarizes the atria. So this little bump here, that's the atrial depolarization. So all the electricity up here tells the atria squeeze, send the blood out. And it goes through the AV node, and when it's going through the AV node, it's just flattened out right there. You've got the gatekeeper just checking out the signal. And then it goes through the whole QRS complex here. And if you go look over on the left, it really kind of shows it in slow motion coming down through. You've got the bundle of His going down through the bundle branches, and then lighting up all of the little Purkinje fibers, and that's your QRS complex. This ST here, this is the ventricular depolarization, so the blood squirts out of the heart, and then you have this resting state here, and this is where I was just showing you with the calcium slow influx. This right here is a really dangerous part of the whole electrical process, because if there is an electrical impulse from like an AED, you're doing CPR, and somebody sends a shock at this time, it'll screw up the whole entire system. So this is a very sensitive part of the whole electrical process in the heart. And that was the one that I was showing you on the earlier slide. All right, let's talk about cardiac output. This is the amount of blood that's pumped out of the heart over about a minute. So when we measure it, it's what's going on in 1 minute. And the factors that affect the amount of blood that comes out of the heart is the heart rate and the stroke volume. So you have how many beats, how many times the pump is pumping out blood and how much blood is coming out. And that's basically your cardiac output over a minute is dependent on those two things. So the factors that are going to affect the heart rate are your autonomic innervation. So when you have your fight or flight response, things like that, setting it off. We have hormones, your fitness level, your age. As far as stroke volume, the size of your heart, again, fitness level, gender, contractility, duration of contraction, and then we've got preload and afterload here, which I'm going to explain in a minute, so I'm not going to explain it right now. But those are all the things that are going to affect your stroke volume. So normal amount of cardiac output over a minute is 5 liters. And then the ejection fraction, this is the percent of the blood that comes out of your left ventricle. Your ejection fraction, the calculation for it is the stroke volume over the end diastolic volume times 100%. And you're like, yeah, whatever that means, Jessica. The stroke volume, that is the amount of blood that actually came out with, when we say stroke, we're not talking about a stroke, we're talking about a heartbeat. So the stroke volume is the volume that came out of the left ventricle when during that heartbeat. And then it's divided by the end diastolic volume, which is how much was actually in there. And believe it or not, when your heart beats, all the blood that's in there is not ejected. Only some of it is. And as a matter of fact, only 50 to 70% of it is. So if you can picture in those pictures that we just had up on the earlier slides, you've got your heart there, and you can picture that ventricle full of blood. With each heartbeat, only 50 to 70% of it comes out. So there is still some sitting in there. So it fills up. An end diastolic volume is the amount that's in there at the end of diastole. After the atria dump the blood into your ventricle before it squishes, that's the end diastolic volume. So that's the entire amount that's in there. And then your stroke volume is the amount that came out. So you divide those, multiply times 100, you get a percent. And the average, you or me, somewhere between 50 to 70%. If a person, your patient, has less than 40%, that's a criteria that ends up giving them a diagnosis of heart failure. So let's talk about preload and afterload as it is related to cardiac output. I have no idea why this heart looks so angry, but he does. Preload, as you can see, it's a measure of volume for the most part. So you can see here it's volume that's being dumped in. So preload is the volume of blood that's in the ventricles at the end of diastole. Well, what is diastole? You have diastole and you have systole, right? Diastole is the process of the atria putting the blood into the ventricles. So when the atria is dumping blood into the ventricles, that's the diastolic process. It's filling up the ventricles with blood. So at the end of diastole, you have a pressure in your ventricles, and that's the preload pressure. That is it, but it's really based on volume. Then you have afterload. Afterload isn't necessarily talking about volume, it's talking about pressure. So you can see on this side there's like a little vise up here because your ventricle has to push against whatever that pressure is. If it's your left ventricle, it's pushing into your aorta. So whatever that pressure is that it has to push against, it's that resistance. That's what afterload is. So even though you have preload and afterload, they're kind of measuring almost two different kinds of units, where one's kind of, preload's more a measure of volume and afterload is more a measure of resistance. But that's what preload and afterload in general are. So you have your end diastolic volume or your end diastolic pressure. Both of those are preload. And when you look in this picture, you've got the ventricles filled with bright green blood, and you have this pressure. So the volume of the blood that's in there is your end diastolic volume, and the pressure that volume is putting against the walls of the ventricle is your end diastolic pressure. And then here you've got afterload, and this is the pressure that the ventricle has to push against to eject that end diastolic volume. So the volume that's in those ventricles has to be either pushed out through the pulmonary artery or through the aorta. And so if you've got pressures in your pulmonary system, you've got some types of lung disease or whatever, it's going to be hard for the right ventricle to push out through that pulmonary artery. If you are hypertensive or you have a problem with your aortic valve, then your left ventricle is going to have really high resistance and pressure that it has to go against. So those are the afterloads that we talk about. Preload is dependent on the amount of blood left in the ventricle after the heartbeat. So we just talked about end diastolic volume. Here, we're going to talk about end systolic volume. So after the blood's squished out, only 50 to 70% of it's squished out, remember? So that other 50 or 30 to 50% is still left in there. So the amount that's left plus the amount that's returning from diastole, that's your preload. So it's whatever was in there before diastole started and then what's left in there after diastole finishes. All of that together, that's your preload. But in the clinical setting, we measure this either by a central venous pressure or pulmonary artery wedge pressure. Put this little picture up here on the bottom right corner because in the clinical setting, if you go into the ICU or you see a critical care patient of some sort and they've got all of these different crazy waveforms up on their monitor and all of these lines going into them, they do insert this measurement device up here through subclavian vein into the right atrium. So you see the little red dot there that's measuring right there. That's measuring central venous pressure, and that actually measures preload. And they can actually feed that same wire on down through the ventricle. My mouse doesn't want to move. Okay. Through the ventricle up into the pulmonary artery, and it just shows you the waveforms as it moves through. So up here in the pulmonary artery, and here they can measure the pulmonary artery wedge pressure. And they do that a lot for people. They're probably doing that a lot right now for the people that are on ventilators suffering from COVID-19 because they have super high pressures in their pulmonary system. And so they're going to measure that with a device that measures pulmonary artery wedge pressure. All right. So let's talk about afterload. This is a measure of the aortic systolic pressure, which the ventricle must overcome. So this is specifically talking about the left side because we're talking about aortic systolic pressure. So the left ventricle is pushing into the aorta, and it's pushing against systemic vascular resistance, also called total peripheral resistance. But this is the resistance in your vasculature, right? So you've got a little sign down there, or a little formula, systemic vascular resistance. Over here's my arrow. Systemic vascular resistance. It's the mean arterial pressure divided by the cardiac output. I know there's a lot of math in this presentation, and those of you that hate math are like, what is going on? You should know these things. Anyhow, so when you're talking about mean arterial pressure, it's really not like this really crazy, complicated mathematical formula. Here you've got your heart. It's a pump, right? And it pumps out. There's your cardiac output. That is not carbon monoxide. That is cardiac output. So you have your cardiac output. That's the volume of blood. That's the blood coming out of your heart. And it goes through your arterial system, meets up in the capillaries, and ends up into your venous system. That's your central venous pressure on that side. But your mean arterial pressure here, if we think about, you have your blood pressure, right? You have your systolic pressure and you have your diastolic pressure. So when you have your blood pressure, you have like 120 over 80, right? That's a blood pressure. Systolic is 120, diastolic is 80. Well, that's comparing the highest measurement, which is systolic, and the lowest measurement, which is diastolic. We just want to know the average pressure overall. Like, if you added up all of the different pressures throughout the cardiac cycle, what is the mean, that's my dog, what is the mean arterial pressure? Well, you can figure that out by knowing this is just the regular blood pressure. So you have your systolic pressure and you have your diastolic pressure. But when you're measuring it, you actually, the full cardiac cycle is 2 diastoles and 1 systole. So the full cycle is diastolic, systolic, diastolic, diastolic, systolic, diastolic. So that's your full cycle, is those 3 components. So that's why, in order to get the average mean arterial pressure, you have 1 systolic blood pressure and 2 diastolic blood pressures. You add those 3 things together, and because you're looking for a mean, which is the same as an average, you add those 3 up and you divide them by 3, and then you end up with your mean arterial pressure. So when people talk about mean arterial pressure, now you know, it's a very simple calculation, and that's what it is. If you divide that by your cardiac output, you end up with your number for your systemic vascular resistance. I don't have a unit on that. It says 700, but it's like 700 dynes per second per, not even centimeters cubed. It's like centimeters to the 5th or something crazy, some crazy unit you don't need to know. But you should know anyway, that it's the most sensitive measurement of afterload. It's the most sensitive measurement of how hard our heart has to work to do its job. All right. Myocardial contractility and heart rate. This is dependent on the stretching of the ventricle from the preload. So when I say stretching of the ventricle from the preload, we think of the heart as like this really strong muscle. It's actually kind of floppy and saggy when it's relaxed. So if you think of like a baggie, like a jewel bag or something like that, obviously it's a lot more, has a lot more integrity than a jewel bag. But if you think of filling that up with water, the bag will stretch a little bit. It's a little flexible. So that pressure and that weight that goes into the bag as you're filling it, that's your preload. So you have the volume, which is the volume of the blood in there, right? But then you also have the pressure against the ventricles. It actually stretches the ventricles as the blood is dumping into them from the atria. So we have this thing called Starling's law, and it's much like a rubber band. It's a pretty simple concept if you think about it. The bigger the stretch, the bigger the stroke volume. So the more you stretch, the more you're going to squeeze out. It's kind of like if you take a rubber band and you stretch it back, the further you stretch it back, the farther it's going to fly, right? So, or if you're blowing up a balloon, the more air you put into it, the farther you let go of it, the farther it's going to fly away from you. So this is the same concept. The more blood you put into the ventricle, the larger it's going to stretch out. And so the more blood you're going to squish out with every heartbeat. Makes perfect sense. However, it only works to a certain point. And then when you stretch it a little too much, a little too often, you end up with a complete opposite effect. We end up going into heart failure, things like that. You think about a rubber band, you stretch it and you stretch it and stretch it. It gets stretched out and it really doesn't work like it should anymore. Same thing with the heart. That's called Starling's law. So one other thing that is dependent, cardiac output is dependent on, is the inotropic ability of the heart. Inotropic, I know you guys have heard the word before and we've visited the word before, but I'm going to do a brief review really quick because you always hear about inotropes and chronotropes and dromotropes, especially in pharmacology, and what does it even mean? So just quickly, inotropes, those are the things that affect the force of the ventricular contraction. And I always remember it because it starts with the word in. So you squeeze in. Every time your heart beats, it squeezes in. And that's an inotrope that helps to squeeze your heart in. Chronotrope, I remember those like chronology, timelines, heart rate and rhythm. So when you just think of a rhythm strip, changing the rate and the rhythm of the heart, that's a chronotrope. Dromotropes we never really even talk about, so it doesn't really even matter. But it's what's left over, which is just basically the conduction throughout the system. So dromotropes will affect that. But just so you know what a chronotrope is, or an inotrope is, because that's what's important in cardiac output. So positive inotropes, things that actually help the heart squeeze hard, are epinephrine and norepinephrine. A negative inotrope is acetylcholine, and this is released from the vagus nerve. This is what happens when people faint. Their vagus nerve gets stimulated. People that are going poop and push too hard, especially old people, and they pass out in the bathroom. This is the acetylcholine that's released from the vagus nerve stimulation. So it tanks their blood pressure and drops their heart rate. So their heart doesn't contract as hard. And so that is a negative inotrope. And then in sepsis, with an infection, you have cytokines that are released, and they have a negative inotropic effect, and they weaken the strength of the contractions. This is why you end up hypotensive in sepsis. Oxygen demand. So how do we maintain oxygen and perfusion of all of our tissues, which is what we really need to do in the basis of all of life? Well, we have baroreceptors that are also called, or baroreceptors, which are also called presoreceptors. And these are in the vascular smooth muscle of arteries, and they sense pressure changes. And based on whether those are set off because pressure is high or set off because pressure is low, the system responds accordingly. So when you have an increased blood pressure, the receptors will react to decrease the heart rate and also decrease vascular tone, which means it's going to relax the vasculature so that it's more compliant. Things can, dilate. You'll have larger tubes for the blood to flow through. If you have decreased blood pressure, you're hypotensive, it's going to increase the heart rate and constrict your blood vessels, make the diameter smaller, and increase our cardiac output by increasing our heart rate. All right, so our systemic circulation. We have arteries and we have veins in the whole circulation. Coming out of our heart, we're going to go right into our arteries through our aorta with our oxygenated blood. We're going to get it to the tissues, and there it's going to be exchanged in the capillaries for the CO2, which is, byproduct of a metabolism. Our elastic arteries, which are our aorta and our bigger arteries that come off of the aorta, those are very elastic. And then as they get smaller, they turn into muscular arteries. And the muscular arteries help to keep things moving through. They're further out, they're smaller, they help shunt blood. And then our veins are very different. They're thin-walled and very fibrous. They're not so elastic. They have larger diameter than arteries. And they contain valves. Arteries do not contain valves. Veins contain valves, and it's helped to keep things moving one way because it doesn't really have the pressure that the arterial system has. Things have slowed down quite a bit, so you need to have the muscles. There are muscles within the veins and the valves to help move it back up to the right side of the heart. So peripheral resistance and blood flow are inversely related. If you have increased peripheral resistance, you're going to have decreased blood flow. And if you have a decreased peripheral resistance, you'll have an increased blood flow. It's pretty common. But the things that affect these are the diameter of the vessel. Obviously, if it's clamped down and really skinny, you're going to have more resistance. It's going to be harder to flow blood through there. The viscosity of the blood is going to affect how quickly it flows. And then the compliance of the vessel, if it's elastic, if it's sclerotic, if it can compensate, that's going to make a difference. Hematocrit, which we always see with hemoglobin, you'll always see what's the H and H. Well, the hematocrit is the measurement of RBCs in the blood, and it's used also to get an idea of how viscous the blood is. The really high RBC count is going to make the blood really viscous, and when you go down to the finer venules and arterioles in the microcirculation, you can end up really clogging things up, and it builds this back pressure that ends up increasing the cardiac work. Okay, moving on to blood pressure. Hang on. You've got your chart here of low to high blood pressure. Measured as systolic over diastolic, as you guys are well aware. Your systolic pressure is the highest in the whole system, so at any point in time, your systolic pressure is your highest blood pressure. And this is based on your cardiac output times your peripheral resistance, as we've gone through. And your diastolic pressure is the lowest measurement in the entire cycle. And this is during ventricular filling. And then you have your mean arterial pressure, and this is the average pressure of the arterial system. We've kind of already gone through all of these, but just so that you understand, when you're taking somebody's blood pressure, what do these numbers actually mean? This is what they actually mean, and now you know. Pulse pressure, you'll often hear this term. It is something that'll be mentioned in certain disease processes, and how do you know if this is going on or that's going on? Well, the patient will present with a narrow pulse pressure or a widened pulse pressure. Well, a pulse pressure is just the difference between the systolic and diastolic. So if you have a 110/70, the pulse pressure is 40. Totally different, completely different than a mean arterial pressure. People often confuse the two of these. Don't do it. They're completely different. Hormones that affect blood pressure. We'll talk about vasoconstrictors. So epinephrine and norepinephrine, I know that they're neurotransmitters as well, but they also are hormones. We have angiotensin 2, we have aldosterone. I'll explain what the little star is there for in a second. And then we have ADH, which is also known as vasopressin. And then we have the vasodilators that are the natriuretic hormones. Epinephrine, this constricts blood vessels everywhere, except in the heart, the liver, and the skeletal muscles. Norepinephrine, when it is functioning as a hormone, which is not that often, it is stronger than epinephrine, but it functions in just the same way and does the exact same thing. Angiotensin, if you remember that from our RAS system, you've got down here, you've got your angiotensin, which can directly on its own influence the arterioles to constrict. So it is a vasoconstrictor. The aldosterone, and why I have the little star there, it's kind of cheating to call it a vasoconstrictor. It's not really a vasoconstrictor, but it does help increase blood pressure by telling the kidneys to hang on to sodium and water. So it's put in here in that it is a response to the need to vasoconstrict, the need to increase peripheral resistance. Aldosterone does that by helping to increase volume. And then ADH, this is released from the pituitary in response to increased serum osmolality. So when our blood is really concentrated, our pituitary says we need water. So you'll have your antidiuretic hormone that goes out saying, telling kidneys hang on to water. It also tells you to drink water. This is what gives you that sense of thirst. So does recording a PowerPoint. Anyhow, so vasodilators are natriuretic hormones. We have A, B, and C. B and P is the one that we usually pay attention to most, especially when we're talking about cardiac. But they help vasodilate us, and they do it by secreting or influencing our kidneys to secrete sodium and water. Sodium excretion is called natriuresis, so that's why these are called natriuretic hormones. And then diuresis is the excretion of water. Now that we've talked all about arterial pressures, let's talk a little bit about venous pressure. This is determined by volume and compliance. And when I say compliance, I just mean by flexibility, ability for the veins to adapt. This is controlled by your sympathetic nervous system, by the contraction of the smooth muscles in the vein walls. And then you have skeletal muscles and your respiratory inspiration. These actually also help to move blood throughout our venous system, not necessarily directly, but as we move our body and we walk around, when they say, yeah, get up and move around and get the blood flowing, it does get the blood flowing just by the contraction of the muscles. And when we take a deep breath in and our diaphragm drops and it pushes on our internal organs, it helps to move our blood through our venous system. The majority of our blood, 66% of it, is actually in the venous system, and the average pressure of our venous system is 10. Lastly, and this is just really basically a little snippet, we've already addressed our lymph system, I'm well aware of that, but just so you know that it is pretty integral at the end of more like the middle, but where our arterial system and our venous system meet, we've got our lymphatic system. And you already know that part. It's connected to our circulatory system on very micro levels, all the way down into our little capillaries. As you can see there, that's a capillary with the arterial and the venules meeting, and then the lymphatic vessel kind of weaved in there. As you can see, the lymphatic system is just a one-way system, so it terminates there at the end. It doesn't, unlike the capillary beds of the circulatory system, where it's just a cycle that keeps going and going and going. Lymphatic system is a drainage system, so it's only going to go one way. And if you remember this picture from way back in the day, when we were talking about osmolality and such, we had our little lymphatic guy over here, and that's where it sits, and it drains, byproducts of metabolism, things that our immune system has grabbed onto and need to drain out. It comes into our lymph system that way. Our lymph fluid comes out of that system. Trying to tie it together here. So as it moves through, it hits the nodes and it slows down. So you're going through the lymph system, and when it gets to the nodes, it slows down a little bit because we've got a bunch of phagocytes in there that are going to eat up the junk and then continue to push it through. Ultimately, it dumps out into the thoracic and right lymphatic ducts, and those just end up draining right into the subclavian veins. So it just dumps out there, and then that's really the end of that system. I'm going to stop here and restart this in a few minutes and record part 2.